out the ways we structure the cities in order to come up health positive. So that is what we're going to be exploring today. We're going to start with thinking about a methodology around a health impact assessment, right? Really understanding how we measure the impact of this using participatory approaches from Mauritius. And then we'll take a step back and hear about a particular project that James and his team have been working on, which cities are involved, what methods have been applied, what some of the key findings are. And just a heads up, we're going to come back to you, right? So what do you think? It'd be great to, there's enough people in the room, you know, we're cozy enough. What cities do you come from? What do you see as some of the challenges? What kinds of evidence do you think would be important? Do you think what is presented today lands? Have you tried that before? What do you think is missing? So it'd be really great to have this as an interactive session. Are you kind of up for it? Thiago, come on, give us a, yeah. Okay, all right. So without further ado, I will start off with inviting Dr. Meelan Thondoo to share some of the findings from Mauritius. I'll just ask you to just give you a little bit of an introduction on who you are, just to save time so I don't do that, just so people know who is in front of them, and then launch in. So over to you.
Thank you. Thank you very much, Tolullah. And thank you, James and team, and also for the ISUH organizers for having us today. So my name is Meelan. I am currently working at the MRC Epidemiology Unit at the University of Cambridge with Tolullah and James. I have a background in medical anthropology, but also in epidemiology. So I do quite a lot of mixed methods research, focusing on health impact assessment. So I'm going first, but I will present something that's not very common in health impact assessment because it's a participatory approach. So before I start, I always like to scan the room, and I'm going to wear my glasses for this just in case. Who here knows what a health impact assessment is? Great, great. So I'm very excited about you on that side of the room. Who of you have actually completed a health impact assessment yourself? Great. By yourself, all alone? Oh, great. So that's really good. That's really good to know. So let's start. And I'm going to put my timer on. I have 10 minutes. So this is my presentation for today. No surprises here. And I will wait. And I will be free for questions afterwards. Starting off, so we do know that environmental risk factors contribute to 23% of global burden of deaths, particularly for transport. We know that it affects health in positive ways through physical activity and social interactions, but also through negative ways, air pollution deaths, traffic deaths, physical inactivity deaths. We're working in the context of low and middle income countries, LMICs, where transport-related impacts on health increase with rapid urbanization and mass motorization, which we do know will occur mainly in Asia and Africa. What's more particular about LMICs is that variation in transport-related exposure can be very high. In some countries, up to 90% of urban air pollution is due to motor vehicles only. So you have two photos here, quite a big contrast, I think you would agree. But I'd like to highlight one similarity, that the under-evaluation of health in the transport agenda is actually a global phenomena. And this phenomena is fueled by car-centric urbanization. What is specific though to LMICs is that these car-dependent designs are imposed at the expense of other means of mobility. And you can see here two-wheelers, walkers, three-wheelers in some settings, etc. So there are gaps in research. First, health is not on transport agendas. But second, there is a lack of tools now to quantify the health impacts of transport. And third, the existing ones are not necessarily adapted to resource-constrained settings. What to do then? So the overall aim of this work was to bring health to the agenda of urban transport by testing a HIA model that is full chain, participatory, and integrated into the policy environment. And we did that by assessing health impacts of transport scenarios in Paul Louis, Mauritius. Anybody's been to Mauritius here? No? Great. So we'll move on to that in the methods. So I applied the main HIA definition of the WHO, which is a systematic method to judge the potential health effects of a policy, a program, but it can also be an intervention. And there is an equity side to that, at looking at how the health effects are distributed across populations. The method has 7 steps. What I designed for this work was a participatory quantitative HIA. It's a bit weird acronym, but PQHIA. I'm not really sure. Sometimes I use it, sometimes I don't. But what's interesting about that is that the model has similarities with the qualitative HIA in the sense that it uses primary data, engagement of stakeholders, and context. But it also has similarities with the quantitative HIA, and you will have a couple of examples afterwards, where I use secondary epi data to do mathematical prediction and modeling. Moving on to the methods. So here's the case study site. If you do know Mauritius from the magazines, people know it for the beaches, but actually it's the most dense country in Africa. It also has a very high increase in vehicle fleet, 625% in the last 20 years. Why is it relevant? It's relevant because the whole country and also the cities are facing common features of urbanization, no? Urban sprawl, increased vehicle ownership, etc. So here's the city profile. Air pollution levels very high, high levels of traffic deaths, and also very limited data, if not any data on physical activity, green space, and noise pollution. So this is how we applied the HIA to an urban transport planning policy and applying a mode share shift to the current baseline situation in order to estimate the amount of deaths. Here, mortality, after which I assess the economic value of mortality. There are 3 exposure pathways: air pollution, PM2.5, traffic deaths, and physical activity. Just a quick overview of the methods, and I want to rush to the findings because that's the most important part. But what I'd like you to remember is, of course, the methods in HIA can be very integrated. And here what I did was primary data collection, secondary data analysis, risk assessment modeling, and knowledge translation, using both qualitative and quantitative data sources. The slides are a bit slow. Starting from the baseline data collection, there are a lot of challenges in collecting data for HIA. But in this case, okay, oh, there should be a place. Okay, great. So in this case, what I managed to do was to collect qualitative data with a large number of stakeholders using interviews, focus group discussions, feedback exercises, but also 600 electronic field surveys in order to collect data on physical activity, health status, travel patterns, and also a large number of documents and data that I got from existing databases, international and local. The reason why I'm raising this is because we do know that the lack of HIA and LMICs is related to lack of data, but it's not always true. And this is what I'd like to show here. Great. So maybe I'll go a bit slower in this part for our colleagues here, and I hope you'll get excited about health impact assessments. So starting off with the 2 first stages of the HIA was scoping and screening. So I spent a lot of time engaging with the stakeholders in order to understand in what context we were placing a model. The baseline data collection and the design of the scenarios was all done in co-design and co-creative mindset with local partners. With the baseline data, I was able to extrapolate current exposure levels, and with the scenario, I was able to decide or define what type of exposure difference I would calculate afterwards. Moving on to the appraisal stage, to the exposure difference, I applied exposure response functions, relative risk, and population attributable fraction in order to estimate the averted deaths and estimate the cost of these deaths. Here are the references for the ERFs and RRs. After which I use the results in coordination and collaboration with the stakeholders to feed it back into the initial context. So this is how we started the HIA. This is how we ended it. So after consulting with them, what happened is that we really realized that engagement at every single step of the HIA was clear. So in the center, you see the participatory approach, starting off with the different stage of the HIA, the different tools that we use to engage. But more importantly, on this slide, is that there were a number of conditions that were important to make the HIA effective. Now having the cost, the social responsibility approach, multi-level engagement, etc. There were 8 of them. More importantly, these conditions were also the same conditions needed if we wanted to infuse the findings of the HIA back into the society once it was conducted. And of course, there were 3 different very high level conditions for that: good governance, evidence-based policymaking, etc. Moving on to the findings. Great, so as I said before, I modeled all-cause mortality effects using 3 different indicators and 3 counterfactual scenarios. I assessed that with natural all-cause mortality rates for adults between 18 and 64. In the interest of time and just looking at the scenarios, I would like you to just focus on the private car mode share. Here in the baseline scenario, through the travel diaries and the surveys that we did in the field with the field workers for more than 6 months, we actually found that 10% of the population in Paul is actually using cars. 54% are actually on foot, which is what you will see with other presentations, quite common in low and middle income countries like Mauritius. So the stakeholders went on and designed these other scenarios. What is the worst case scenario? What is a medium case scenario, and what would be the ideal case scenario, and how can we make sure that health can be a benefit and in which scenario that could happen. So in the first one, we doubled the car trips. If you look under the pie charts, you'll see the main themes. So first scenario was to double the car trips from 10% to 20%. And the second one was to halve the car trips, bringing the car trips from 10% to 5%. And then in the last scenario was to remove cars altogether. So from 10% to 1%. At the same time, we also modeled together what would be the most important other mode of share of transport. In the second case scenario, you see that while we halve the car trips, motorcycles go up, which is actually what happens in real life or in Paul. In the last one, if we remove the cars and we remove the motorcycles, then the public transport goes up. This was a really great process with them because they knew what was happening, right? But it was hard to build the scenarios without speaking with them on a regular basis. Here are the findings. As you can see here in the red squares, there were 2 scenarios that created an increment in premature deaths. That means that there was more people dying if we doubled the cars. There was more people dying if we halved the cars. Right? And in both cases, whether we decrease or increase cars didn't really matter. What really mattered actually was the level of physical activity, which was the exposure pathway that had the most impact on health. And we see that again and again in many of the health impact assessments of transport. And so it was the ideal case scenario that won. That won in a lot of sense. If you look at this graph on the right, all of the health impacts are underneath the baseline. So that means that we're saving up to 14 lives per year, and the government can save up to 23 million rupees. So I know you're saying 13 lives is not a lot, but Mauritius is very small, and 13 lives a year is 40% of all traffic deaths. So it is a lot, and it's a lot of money as well. Great, so I'm gonna end here with 2 slides. First is that we triangulated these findings with qualitative findings and did a summary, right? So as a recap, policies to reduce cars are not enough. To achieve health benefits, policies should actually aim to restrict all form of motorization, particularly looking at motorcycle use, and that these ideal situations could actually lead to 20% of savings. So why these results were so important? I went on with the team, and Mark is here, and we have also colleagues here, Catherine from IS Global, to look at what's happening in low and middle income countries. Why is this so important? Currently in LMICs, only 26 out of 156 countries that we reviewed are assessing impacts of transport. In those, only 12% are participatory. And in those, none of them report on how to actually do one. Second thing, in these countries, very few of them have HIA policies, which really restricts implementation of these type of methods. And third, small cities, big needs. Although we're growing cities, a lot of the policies are actually not responding to the needs of urban poor. And last thing is that there's this very big myth about participation being expensive. it actually only cost us 7% of the whole program. Lots of strengths and limitations, mixed methods, in integration of policymakers, very strategic partnerships, but also limited sample size. There was a lot of implications in the modeling, the use of ERFs. Some challenges from the field, monitoring stations, availability of stakeholders, and of course, quite a lot of concern in terms of scientific validity, and we tried to limit those by doing sensitivity analysis. So implications for future research, and Tolu, I'll hand over to you, is health impact assessments are important to address health inequity, especially in countries like Mauritius and different kinds of countries where the resources are different from those from high-income countries. Transboundary health threats, climate change, and innovative data systems are important to way forward. Thank you very much. Oh, just a last note before I leave. So when I did this work, I wasn't at Cambridge yet, but Cambridge was always on my thank you slide. So thank you very much. Thank you, James.
Before you go, can I just ask one kind of quick follow-on question? Because obviously this is looking at a health impact and it's quite striking. How was this received and what happened next? Just in terms of, did that kind of motivate any kind of change in policy, or how did that tell us a little bit about what happened next?
Yes, what was supposed to happen next was Mark was supposed to come and, and give the presentation to the Prime Minister's office. But what they actually did is that they took the results of the health impact assessment and then went on to design a metro public transport system in Mauritius. So they did use that. And I have to say that, and they are on my thank you slide, none of this work would have been possible without the ministries. And they were my main stakeholders throughout the project. So yeah, we did get a public transport innovative project out of this. So I'm very happy and very thankful.
Great, thank you. What countries do we have in the room? Shout out what countries or cities. Jordan? No, just whichever you are prepared to be quizzed on. Jordan? Cameroon? USA? Italy? Do you know the walking mode share in your country or city? Do you know what proportion of the walking mode share? So what proportion of transport trips are? Okay. 5% walking. Okay. I don't know, but the point is to think about, right? I'm going to put James and Lambert on the spot because they will tell you. So one of you can kind of Google quickly whilst the other was talking, because it's important to think about, when we talk about these global type approaches, in some places we're trying to preserve existing healthy and climate resilient behavior. In some places we're trying to shift. So the approach to action can be different, and it's important to know what the starting point is and recognizing is different in different contexts. So with that, I will hand over to Lambert, who will introduce a little bit about the project that you did in the cities that you worked on.
Yeah, that's encouraging. Check the slides are moving first. Oh. Okay. Sorry. Spoiler. Okay. Thank you very much, Tolu, and thank you everyone for being here today. I'm Lambert, and I study health impact assessment, modeling health impact of transport in African cities for my PhD, and I'm supervised by James, who is sitting here, and Tolu there. So nice to have them in the hall at the same time. Okay, so I'm going to do two presentations. This first one is a premiere of what we do. As Meelan indicated, she covered a full chain health impact assessment, and in the quantitative part, there are so many methodologies. There are many things that you can do. And we focus on trying to improve the methodology of quantifying these health impacts. And we are approaching it through modeling. And so for the next couple of minutes, say 10, I want to run you through bring it home in terms of the things that we do and so that you can understand more of the kind of findings that we've had through our work. So I'll look at sites where we're working, and then in the second bit, when I come after James and Haneen, spoiler already, would have presented more details of some pathways. Okay, forgive the slide, it's not my fault, but because there are about 30 cities here that we're trying to show, we might have, so we have cities in Africa where we are working about 5 cities. So you would have a city in Ghana, Accra, and some in Kenya, some in South Africa, if you see there. And Mauritius, still we included Mauritius so that we could be comparative with other cities. We have cities in India, 3 of them in our analysis, and we do have cities in Latin America, some larger cities and then some smaller Chilean cities. And we have tried to bring these together in this study so that you would be able to see and make some bits of, and compare them. Now, just a bit about how we approach health impact modeling. Essentially, in these cities, we want to gather data, and lots of data. And so you can see from demographic data, burden of disease in the population, air pollution, all the way to travel behavior that Meelan mentioned again. And what we want to do, we want to pass them through about 3 pathways that we focus on. That is either injury, air pollution, and physical activity pathways to health. And we are looking at getting health outcomes. And currently we focus on deaths and years of life lost. So based on the data that we input through this, our model, in an integrated way, we are able to have outcomes to talk about health impact of different travel behaviors in cities. I want to still mention here that you see the volumes of the amount of data. It does mean that there's a lot going through in terms of checking, in terms of making sure that things are consistent all along. And I would like to just pick one of these, travel behavior, and just walk through what it means as we do it. So data comes, travel behavior. This means how people are traveling in a city, how much time they spend using different transport modes to commute or to go wherever they want to, which means how, and are they using walking, are they cycling, are they driving or public transport? And because this can come from anywhere, primarily we try to focus on travel behaviors data, travel surveys, sorry. So, but we also have time use surveys as sources of this information and others, and they can be incorporated in different forms of surveys. So we need to sort this out, and part of the things we do is to kind of identify this protocol through which we can process huge data sets and harmonize them so that we can compare them across cities. And this is one of the protocols that we are currently using to input data sources from different sources and be able to bring them to forms that we can compare. And so what we see if we've run through data, remember I'm just focusing on travel behavior here, you can see for African cities, the ones I showed, and Indian cities comparatively, Tolu was giving you a premiere of what walking would be. You would see how walking is. It varies again, but it's higher compared to other cities that you see. And you can see public transport represented as bus is second highest in almost all the cities, almost consistent for African cities and Indian cities. But for Cape Town, which is a bit standing out, you would see that walking is rather lower and car is higher. I'll go to Latin American cities. Here we are looking at two sets of Latin American cities, the larger cities and the smaller cities that you see later on. But what you see here immediately is that walking is rather lower compared to what we saw in African cities, despite the variations that we saw. And again, you can see public transport is significant, but car driving comes out quite strong here in most of the Latin American cities, the larger ones. And in the smaller ones, more or less consistent across, but these are Chilean cities. So we went from larger Latin American cities and then segued to, or focused on one country and the smaller cities there. And this is the kind of mood shares that we are having. So just to reiterate that the mood shares would vary, there will be similarities, and there are things that we can say about these cities when we have this, we can process this data set. Now, ideally, what we want to do is that when we know how people are traveling, and we, as Meelan highlighted, it affects health in many ways. We want to see how by changing these modes, we can, does it affect health? How much does it affect health? But we want to understand how to change the transport mode shares in sensible and logical ways. It could come through participatory approach, but when we're dealing with larger cities, many cities, you also might want to brute force and use methods that, indicative approaches that cities can pick from there and refine with participatory approaches. So I'm going to just show you alternative ways that we use to do the scenarios that are then subsequently applied in the results that you see. Now, we divided our distances that people traveled in cities into 3 bands, the shorter, the medium, and the longer distances. And you can see here that for each of these columns stands for a mode that was in the mode share. So you can see like bus. For bus, you have a lower percentage doing the shorter distances, while a higher percentage of those using buses are traveling in the long distance band. But when you go to pedestrians, the higher proportion of people are doing in the short distance band compared to the longer distance bands. This can also be seen if we look at just the distance bands themselves. We can also see how people are using those different modes. And you can see that in the shortest distance band, again, the highest travelers, the highest people using it are pedestrians. And in the medium distance band, you can see that car is predominant. And then when you go to the longest, you're having car and public transport competing. So how do we reach our scenarios that we assess then? We decide on plausible changes that can further be refined. Say if we want to increase cycling by 5% in a city, how that is operationalized is still another thing that needs a lot of approaches. But then what we do is we want it to reflect what is going on in that city. And so if, for instance, cycling, we want to increase 5% trips of cycling, we looked at the ratio in the different distance bands so that we can pool relative trips into each of those distance bands. So we'll be pulling, for instance, 40% of trips in the short distance bands for cycling, 50% in the medium distance, and maybe 1% for the long distance. This is to replicate what is happening in the real population. And so just having this in mind on how these scenarios are generated, so that when the next presentations come, you can now understand how the results come about. So I think I'll stop here for now and give the floor to next speakers who would elaborate the next bit. Thanks.
Thanks, Lambert. So, I mean, just maybe to just go over that because it's a little bit tricky on the scenarios. So what we're trying to do is there's often a challenge between trying to do scenarios that are consistent across places and across modes and that are realistic in terms of what you might actually expect to change. Because somewhere with like 0.5% of cycling, probably, you know, it's going to be a lot to get to 3 or 4%. Somewhere that's at 15, 20%, you might easily expect it to get, you know, might be able to go up to 30%. So, you know, that's a balance we've taken. We've tried to take this 5% mode share shift for each of the modes. But within that, in a cycling scenario, we assume that many of the trips are going to come from the shorter distance, while in the bus scenario, we assume that more of the trips are going to come from the longer distance. And so we split it up into these bands, and while it's 5% of trips, they're different kinds of trips that are shifted within each scenario. So it's trying to be as comparable as we can, but at the same time, having an element of realism within it. Okay. Right. I'm going to talk first of all about the kind of who hit whom, or the collision matrices that we create, about injury burdens, then about risks per distance. So, I mean, international comparison of traffic injuries is often at the country level. And it focuses on the victims and not the other vehicles involved in the collision. We have tried to do some analysis and work to shift that down to the city level and look at all of the people and the vehicles involved in collisions. We have done a lot of work, as Lambert said, a lot in trying to combine all these cities. It's a big project in terms of harmonizing of data, trying to do as comparable as we across many different places, and assessing the quality and trying to fill in kind of gaps and so on. Here I'm talking about the who hit whom issues that we did on a kind of a wider number of cities. There's a kind of prior piece of work that feeds into the health impact modeling. And we looked at a large number of cities with more than 500,000 people where we had case level data on the deaths. And as you can see, the cities, the data sources, the numbers of cities in the different countries that we have. And we work to harmonize the travel mode categories and as much as possible to work to harmonize to the International Classification of Disease definitions. And when we're talking about these kind of who hit whom matrices or the kind of collision matrices, this is the kind of thing that we're talking about. And we treat each collision or each injury as involving one or two parties. We recognize that some involve multiple vehicles, but we simplify to this. And the injured party is the victim, and then the other person or vehicle involved in the collision is the striker or the other vehicle or whatever you call them. Now, a collision can have multiple victims of different modes and therefore can be represented multiple times. And so potentially if a car and a motorbike collide and the car driver's the motorbike driver's hit is injured, that's one victim. But if the car driver is injured too, that's another. And so for the motorbike, the striking vehicle is the car. And for the car, the striking vehicle is the motorbike. So it's not about attributing kind of blame. It's about a way of counting all the vehicles involved in the collisions. This is just some about the kind of the quality assessment or the kind of data, just to indicate some process we're doing about, you know, how much of the data with the victim and the striking vehicles were known. And yeah, this is a filled in example of the who hit whom matrix. This is multiple years. That's why you've got fractions of, you know, rather than whole numbers here. These are fatalities. Fatalities are where we think we have, you know, the robust enough data for the injuries. We don't, we're not confident enough in the data. So, yeah, so NOV is no other vehicle. So that would be 127 car occupants died, and there wasn't registered as being another vehicle involved in that collision. Yeah. For cycles, there were 10.5, not recognized with any other vehicle involved. Some of these, of course, can be misclassified. Others with bus, with car, with motorcycle, and with truck here. Now, of course, there is often, you know, problems with this data, and we work with it the best we can, but we see the limitations. When we look at the country level summaries of what we have, these was for Brazil, Canada, just giving the numbers of deaths, the numbers of cities, the population. And here you see the big differences in terms of the shares of victims. So this, of course, the risks are very different in these cities, but this is the share of victims that we're looking at. And you see, obviously, in some places, it's very high percentages of pedestrians, much lower in the US, but also lower in the kind of the UK or India, relatively low numbers, but varying of cyclists, quite different levels of motorcyclists, and you know, most places quite low levels of cars, but not in the US where it's quite high because there's relatively so many cars involved, so many cars. But then you can also see it from the perspective of the striking vehicle, the other vehicle involved, and you can see, like in the US, it's like kind of 87% the car, while in India that's only 32%. Is the other vehicle involved. Then we did some clustering analysis. We clustered the data. We came up with these different clusters, what the cities were like. And here we see one cluster that was only the US cities. And you see here a very stark pattern of cars on their own, hitting trees or fixed objects, cars in collisions with other cars, pedestrians hit by cars, and that makes up the vast majority of the deaths. Then there's another cluster of some UK and US cities, and we see it's got a bit more messy, a bit more complicated here with the motorcyclists, and some more pedestrians and things, and we see pedestrian by car, you know, a bigger role than just the cars. And then you see some of the lower middle income country settings. Now, we want to update this with some of the more cities we have, but what you see here is it's complicated and much, you know, this is the point Rahul makes worked on these analysis. I mean, it's, you haven't just got a simple one or two cases of cars and pedestrians. You've got motorcycles and trucks, you've got pedestrians and trucks, you've got motorcycles and motorcycles, motorcycles by bus, cyclists by bus, cycles by car, you know, car by car here. So it's a much complicated pattern. So thinking about solutions is more difficult in this context, or at least solutions need to be mindful to this context, reality. And yeah, I need to move on, so I won't focus on this more mixed one. And yeah, this is just the cities that were involved in the clusters, but I want to get onto some more results. And yeah, I mean, this just brings up the same point that in the cluster here, the top three make up a very high percentage here, the US cluster. In this cluster, they make up a much lower percentage. But again, I want to move on. Injury burden. This is just WHO data, not just WHO data, this is WHO data. For the numbers of traffic deaths per 100,000 population per year. Norway is just after Singapore, best in the world. Put the USA on, suddenly the scale has to jump up a bit. Obviously, the USA does much worse than, you know, other high-income countries. Then we put on what we've been doing with our analysis. Oh, no, sorry, this is still at the country level. Yeah, this is still the country level. This is putting a load of countries from the Americas, India, and Africa. Can you see the countries? But yeah, I mean, this is like kind of Mexico, Argentina, Uruguay, Chile, Colombia, India, then Brazil, South Africa, Ghana, and Kenya. Okay, then we put on our cities as well. So this is just burden data. And what you've got is you've got the country, then you've got the city. The country is from the WHO, the city is our analysis, yeah? And we try to include some uncertainty around this, but of course, this only represents some of the uncertainty that we actually have. And I mean, one of the problems is that all the data are underreported. The WHO have modeled increases. They have based on a reporting rate, and they have modeled this as higher than what is reported by the country. Here, we are reporting just the numbers we have. In our actual impact modeling, we increase this based on some estimated underreporting. But this is just showing the raw. The problem is, it's like, how do you, we're comparing two things that are both underreported by an unknown amount. And usually the city data is going to be more reliable than the country level data, because particularly for large cities, you've got better reporting. Yeah, this is the small Chile, and then the small Chilean cities, showing again quite a big variation in the numbers of deaths. And then here we see the African, the African cities and countries: Ghana, then Accra, Kenya, then Kisumu, Nairobi, Mauritius, Port Louis, South Africa, and Cape Town. And India and the Bengaluru, Delhi, Visakhapatnam. So combined with the distance data that Lambert was talking about, from this, we can then also estimate risks per distance kilometer, per distance traveled. So for this, we need the deaths by mode and we need the distance by mode. Both of these are, of course, uncertain. And we've tried to represent some of that. Okay, I mean, yeah. Here we see cyclist deaths per billion kilometers. We see Denmark and the Netherlands, kind of some of the best places in the world, probably. Germany, and then the UK, and then obviously the more problematic position in the US again. Here are for our cities, the kind of estimates that we've come up with. Big variations in the risks. It's jumping. And this is, yeah, this is here's putting on the other countries to give the context of what we're seeing for these risks. With the US here, yeah. This is just taking off the worst cities, just because it allows us to be a bit more comparable when looking at the other cities, yeah? So we're seeing we've taken off Cape Town, somewhere else, and you can see a bit more the differences between, you know, Bengaluru, Santiago, Medellin, down to what seems to be doing well around Buenos Aires and Nairobi. But it may be also misreporting. I mean, the Buenos Aires, there may be more underreporting, and Nairobi, there may be more issues around potentially pedestrians being classified as, cyclists being classified as pedestrians. Here we see pedestrian deaths per billion kilometers. Notice that these go up higher than cyclist deaths. Pedestrian deaths are per kilometer. Pedestrian walking is more dangerous in most places per kilometer than cycling, though there may be other confounding factors that explain that. Here we are putting our cities. Here we see our cities. Again, oh, you're missing the edge of it, but it goes up to 600 here. Here, yeah, putting again the best places on the US here, and then going, yeah, all the way up to the 600 or so. Taking off the top couple just to allow a slightly better comparison, going up to what, 350 now. Motorcyclist deaths. This is our cities here. Motorcycling poses a risk, of course, to others as well as to the motorcyclist, and we have got data on that. We could present that, but I haven't got time to go through that today as well. I haven't got that for the international places, but you see going up to some potentially, again, very high numbers in Cape Town of kind of, 600, 700. Just taking off the top places again to make it slightly more, so you can actually see the variation of some of the lower places here now going, you can see this, I think, going up to 250 in Sao Paulo, but up from about 25 in Cali and Colombia. So big variations within in the same continent with large cities. And I would be I mean, there is obviously quite a lot of uncertainty, but I mean, clearly there are some very, very real differences here. Okay, and I think now I pass over to Haneen, who's going to talk about the air pollution work before Lambert brings it back together with the health impact results.
Okay, thank you, James. Do I need to pull up my slides or are you going to pull them up? Sorry, where are the slides? Oh, okay. Okay, I'll be patient then. Anyway, I'll introduce myself. My name is Haneen Khreis. I work at the University of Cambridge with James and Lambert. And I'm part of this is not the first slide, we'll go back, but I'm part of the health impact assessment modeling team, or the public health modeling group as we call it. Okay. So as Lambert started, he said we look at 3 pathways between transportation and health, and James already talked about the injuries. And there's also physical activity, and I'm going to talk about the air pollution in particular. So as a very quick background for those of you who are not familiar with this, which I doubt is many, but air pollution is a huge health risk factor. The health effects of air pollution vary from premature mortality to a wide range of morbidity endpoints. Now, one of the main pollutants that is studied is PM2.5, or fine particulate matter, and it has so many sources like agricultural, biomass, burning, and transportation. And unfortunately, I cannot see the slides here, so I'm gonna have to turn, oh, here we go. Okay, that's better. Okay. And the sources of emissions and the sources of pollution in many countries are relatively well characterized. But in low and middle income countries, that's not the case, partly because the characterization of these sources requires certain models like chemical transport or dispersion models, or the creation of vehicle emissions inventories. And these things, these are methods that are relatively accessible, I guess, in somewhere like the UK. But they are more data and expertise intensive. And one of the motivations for the work we're doing here is to come up with perhaps a slightly more simplified method or modeling approach that can be applied in places where this kind of data is not readily accessible. So this is all within the framework of the Integrated Transport and Health Impact Modeling Tool, or ITHM. And the objectives of the work that I'll be showing you today, the first thing is to identify the contribution of transportation to fine particulate matter, both the emissions, so what comes out of the exhaust, but also the ambient air pollution, or what we're exposed to, using methods that are transferable to low middle income countries. The second, and I think that's the innovative part in this model or this method, is to come up with a way to assign personal exposures to PM2.5 rather than assigning exposures at the geographical, say, census level. And to also account for ventilation rates, because a lot of our subjects are moving around in space and time. They could be cycling, they could be walking, so their ventilation rates are different than if you assume they're just at their residence or they're not moving. So we also account for that, and I'll show you how. And the last thing is to assess the impact or changes in PM2.5 personal exposure as a result of alternative transportation scenarios. And we've already mentioned one, which is the 5% increase in any mode, like a 5% increase in cycling that Lambert talked through, and I'll be showing some results of air pollution if we apply that scenario. So I thought this slide might be helpful. I'm not sure, but I'll try. This is kind of the overarching methodology. And I'm going to break it down in the next slides, but I thought maybe it can show how everything fits together. So we start with ambient PM2.5 concentrations in our cities of interest. We say how much of this is because of transportation. And the portion that is because of transportation is the portion that we adjust. And the rest of the proportion is the portion from other sources like industry, agriculture. We don't touch that in our models so far. So then we take that proportion from transportation, and we also find out how much of this is coming from cars, from buses, from public transport or buses, from motorcycles. And we adjust that proportion based on the adjustment we make by distance. So say, for example, if the distance by car is reduced by 5%, then we go ahead and adjust PM2.5 from cars by that 5%. And then we go back and add that proportion from all the other sources, which we didn't touch. And we come up with this new ambient air pollution concentration after the application or the implementation of the scenario. And then that is basically what you have in the ambient air. And then we adjust that for personal exposures and ventilation rates. So I'm going to break it down and show you exactly how we do this and where the data sets come from, because all of this is publicly available data sets. So they're quite transferable. People can do this themselves. So the first piece of information is ambient PM2.5 concentrations. This comes from the WHO source apportionment database, which is publicly available online. And we also have another source, which is the WHO air quality database, where we don't find air pollution concentrations in any of these two. We try to find local data sets, and we had to do that in the small Chilean cities because they were not indexed in those kind of bigger data sets. So as an example, I'm showing that level PM2.5 in Santiago as 32 micrograms per meter cubic. The second piece of information is the percentage of that amount, that 32 micrograms per meter cubic, that is due to transportation. And that also comes from the WHO source apportionment database. And where that is not available, there was another systematic review that built on the WHO database, which we used. And there were some cases where we couldn't find that percentage. And in that case, we just picked the closest city to the city of interest with kind of similar properties. Like, for example, if it's a coastal city, we made sure that we pick a coastal city for that number. And that gives you the percentage of that ambient PM2.5 that is due to transportation, which is the percentage that we will adjust. And then the third piece of information comes from EDGAR, the emissions database for global atmospheric research. This is a vehicle emissions inventory. It also has emissions from other sources, but we're only interested in transportation now. So from EDGAR, well, this slide is a bit complicated, but the gist of it is that we have maps at 11 kilometers by 11 kilometers across the whole world. And at each grid of those, you can find out how much of the emissions is coming from cars, from buses, from motorcycles. And as I said initially, we use that data for the adjustment. So EDGAR has some limitations, which I'm listing here. The database has many uncertainties. It is also known to underestimate PM2.5 by approximately a factor of 2. These are issues that we're going to look at and try to improve in future work, and I'll briefly touch on that towards the end. So this is how the data set from EDGAR looks like, just again for Santiago. So we've got the buses are shown to contribute to about 6% of PM2.5, motorcycles, cars, heavy trucks, and light trucks. Now, this data set looks very different for the different cities. So it's very context and it's very local, very context specific. Some of the cities you see that the cars, for example, are responsible for less PM2.5 than buses. So it really depends on where you are, and this method can capture that. So with all this information, if you think about the first framework that I showed, we use this to calculate the new concentration that people are exposed to. But then the question is, what are they actually, what is the dose that they're inhaling? So for that, we find out what are the air inhalation rates per activity. And these are the numbers that we use. They come from the WHO HEAT tool, or the Health Economic Assessment tool. Pretty standard, and as you can see, they're higher for active modes like walking and cycling. You're inhaling more air, and much less for being in passive modes like cars and motorcycles and transit. And then we also account for an assumption of 8 hours of sleep a day for each of the subjects on our network, and everything else where you're not sleeping and you're not in transport, then you're at rest. And then we also apply a factor to adjust for on-road concentrations. And what that means basically is if you're on a road walking or cycling, you're exposed to more air pollution than that ambient air pollution, which we calculated. And these are the ratios. So cycling and motorcycling, we multiply by 2. For walking, it's 1.6, cars 2.5, and public transport 1.9. These also come from the HEAT tool. Now, I mean, the calculations are online. I'm not going to bore you with them, but the underlying method just basically assumes that changes in the distance by mode is equivalent to changes in emissions and concentrations, and that's how we do the modeling for the different scenarios. We also assume that there is no impact of chemistry or from air pollution from other sources, which is a simplifying assumption, but I think, you know, appropriate for the case of kind of upscaling this method to places where this work has not been done before. And we also assign the exposures based on the individual levels, as I said, not based on census data or geographical location. And using this method, if you have local data or on any of the parameters that I showed, you can actually just plug them in and run the model. And therefore, it's relatively flexible. So going back to the scenario that Lambert touched on, what if the question here is, what would happen to air pollution, to individual exposures if we increase cycling, driving, public transport, and motorcycling by 5%? Compared to the baseline. So we've run these numbers for 28 cities, which Lambert also showed. I'm just going to show the results for a couple of cities. And the first one is Santiago, where I showed you some data from. So these are the results. And the first column here, this is the individual mean. So this is exposure at the individual level. And the last column here is the ambient PM change. So this is across the city, if you may think of it this way. And then you can also see the distribution of the personal exposure on the 5th, 50th, and 95th percentile. And if we look at it, this is the baseline PM 2.5. This is what it becomes. It reduces very little, but still. With bicycling, it increases with driving and reduces with public transport, and also reduces with motorcycling. And you can see here the levels at the city as well. So yeah, the scale is different on these two graphs, so just don't try to compare them, I guess. So this is Santiago and this is Sao Paulo. The numbers, the levels are different, but the patterns are the same. Basically that we see cycling as a beneficial scenario, and then public transportation as well. But not driving and motorcycling. But as I said earlier, these numbers and these results are very context specific. So if we run the same analysis for Bogota, the results here are different. We find out that public transportation increases personal exposures because the emissions, according to Edgar in Bogota, come in big part from public transportation. Or the other way around, driving reduces air pollution in this case. So again, they're context specific, but some of the results are you could think questionable, but we couldn't find kind of local data, something that we will look into in the future and hopefully understand it a bit better. So just to summarize, this is a method to estimate personal exposures to PM2.5 in low and middle income countries and estimate the impact of alternative transportation scenarios. It's standardized, it's flexible, you can apply it with your own local data points if you have them. It is limited by certain simplifying assumptions, which I've already run through. And we know that there is a problem in the vehicle emissions inventory. And that's why in the next slide with the ongoing developments, one of the points here is to do emissions modeling bottom up. So starting with vehicle emission factors and the distances of different modes and do it this way, which might give us some more confidence and some different results. And some other ongoing developments are here as well. I won't get into them, but I'll leave them on. And my final slide is just an acknowledgement of the team, the ITHM Global team. And I think I'll pass it back to Lambert. Thank you.
So we'll have that. Bring it together. We'll pause for a little bit. Just one question, two questions, and then we'll go to the other two. Just make it all make sense. Oh. One question for Haneen, not waiting for the slides.
Oh, thanks. If you could speak at all to the improvements in emissions factors that you're looking at, like, are you preferring to use like a fuel-based emissions factor or distance-based? And are emissions factors allowed to vary between cities according to different road conditions or different driving conditions?
Okay, so the way I've done this in the UK before is to run an emissions model that varies based on speed and distances, and then fuel standards and technology, like, you know, Euro 0, 1, 2, 3, 4, 5. And so on. I'm not quite sure how it's done in Latin America. For example, I know that the EPA MOVES model is used in some Latin American cities, but it could not, possibly it's not fully transferable to some of the cities we're looking at. But we have some collaborators who have certain emission factors in certain cities, and we'll be looking into this, but I don't know exactly how it's going to work. But it should be fuel-based, it should be emission standard-based, and it's definitely distance-based because we have the distances by mode in the travel survey. So that's, you know, that's the big point, that we want to use those distances instead of the distances that come from EDGAR, which don't necessarily match what we have.
Lambert's bringing the physical activity side of things, we had injury, air pollution, physical activity, and then we can kind of do the big picture all together.
Thank you. And just to reiterate that all these are going into the model at the same time, though we present them as different streams, but they are fitting in. And so you can run this at one time in our package and then get outputs that can interpret. So for physical activity, I've kept it quite short because I thought people would see what we did on the other day, but this is how physical activity looked like at baseline for some African cities. And these are just averages. And this comes from physical activity from walking and cycling in the travel, as well as background physical activity, non-occupational physical activity that individuals accumulated. And then we summarize this as what we see in baseline. And there's variation for both African and Indian cities, and some having quite high baseline physical activity. So just as similar to air pollution, we try to see what we can see the distribution here, what happens at baseline, and as we shift to different modes, how individual level physical activities change. And so this is just for one of the cities. But what I'm going to do next is just to bring these now together to see how we combine all these three pathways to see how the health impacts look like in our analysis. And this is the motorcycle scenario where we assumed a 5% increase in motorcycle in the city. And we looked at what is happening in African and Indian cities. And I think everyone can see here, that injuries in red is dominant for motorcycle scenario. And every other city, almost no city is gaining anything when you increase motorcycle by 5% in these cities.
And 26 per 100K is standardized.
Yes, thank you, James. So it's per 100,000 people, so of the population, and per year. I would move to the next because they are almost the same, but then just to see how they are differing. So this is what happens in Latin American cities. Story is motorcycle seems not very safe for all the cities. And for small Latin America, yeah, I just looked at larger ones. I'll go to the cycling scenario. And what we see here is largely beneficial for most of the modes. A few cities did not show good, for their injuries didn't improve, but overall still you have positive benefits for all the cities, as you see, both African and Indian cities for that scenario. We can see that in Latin American cities, however, we have injuries are, significant, but still when you average out both three pathways, cycling scenario still yields positive benefit for each of these cities. In smaller Latin American cities, however, we are rather seeing that for a few cities, you can see Cali and this and San Antonio, that their injuries are quite high, such that when you average out for a cycling scenario, it's actually negative. But then there are possible explanations that we get through data, but let me just go through these results. And then for bus scenario, just almost like cycling scenario, we're seeing huge benefits for almost all the cities, and similar for African and Indian cities. Same thing for larger cities in Latin America. So we could also further split, because we do this, and as I mentioned earlier, there's a lot of checking and a lot of trying to see what is going on at every stage for consistency, and everything is balancing up. We can see the kind of benefits we are having when we just look at air pollution and physical activity. Combining them together, we still see benefits, and these benefits disease-wise are looking at COPD, different diseases here. There are neurological diseases, type 2 diabetes, and we just see how much that and all is also normalized per 100,000, what is going on there. So let me summarize by saying that this method can be applied to a whole range of cities, and giving results that are comparable across multiple settings. The outputs are integrated, which means that there's no double counting as would happen in many cases when you want to use one approach. But then there is this huge checking steps that really allows you to have confidence in what you're doing, the consistency and removal of errors. And of course, just wrapping back to what Meelan said, there's need for engagement with other people who are interested in health impact of transport to see how this can be applied and used by practitioners. So thank you very much.
So we're going to end with, are you going to? So we're going to end with Thiago kind of talking us through kind of the first question I asked Meelan around the so what, right? So how can we push the policy side of things to, really? Okay, okay, online, okay, fine. I'll allow it. So just to kind of push through, how do we kind of make this, turn this into a demand for healthier transport policy? But before we do, kind of, because that's a kind of slight shift, we take a few more comments or questions specifically for Haneen, Lambert, and James.
Yeah, I just had one, because coming from the UK, we often have killed and seriously injured altogether. And I saw that in some of your data, it was the deaths, and then later on, physical injuries were being mentioned again. I just wondered the clarity in that, when it's just the death data, and is it that the seriously injured data isn't available? Because you said saving 14 lives, but I was thinking, and there's a lot of seriously injured saved in that as well that we're not seeing.
We're just dealing with deaths in this. I mean, in the UK, serious injuries are underreported, but I think the data are usable. But to try to do it at this scale for this many countries, the injury data is just not of a quality consistently that we can use. Yeah.
Yeah, I had a question about, so the modeling of the scenarios, and you guys were talking about how you modeled scenarios of increasing one mode at a time by 5%, if I've understood that correctly. I was wondering if you've looked at scenarios in which you change, more than one mode at a time. So, because for example, you were showing about how when you increase cycling by 5%, you have a lot of positive health impacts, but then you have more road traffic incidences. So then I was thinking, well, if you modeled a scenario where you increased cycling by 5% but decreased cars by 5% simultaneously, would you then see fewer road traffic incidents and then have an overall improved impact?
I mean, obviously the cycling is coming from different modes. And I think one of the reasons that, say, the bus scenarios are particularly good in terms of injuries is that they are taking longer car trips. So they're taking more car distance off the road. So our injury model is based on the risk that each mode faces, but also the risk that each mode poses to everyone else. So when we're taking off in the cycling scenario, we are reducing trips from taking trips from walking, taking trips from cycling, taking trips from driving, and so on. And so, of course, the shift in injuries depends on the risks that those modes faced as well. So cycling may be quite risky in one place, but if it's coming from walking and walking was even riskier, then that would actually result in a reduction of deaths. But we can do an awful lot of things with the scenarios, yes.
I think I just had 2 comments, one for Marcus. I think for the injury data, one of the main challenges that we had in Mauritius was that the records that we access, police records, hospital records, and then the actual statistic records, they're not integrated, and sometimes they contradict each other. So that's what James was saying, not only in terms of the quality, but also the process of integrating the data is very complicated, much more than what we think. The second comment I had is in regards to different cities of Africa. I think when we're talking about walking, we automatically think that walking more will bring more health benefits. But because it's so dangerous to walk, when we increase walking and decrease car, we're also increasing deaths because they're exposed to injury. And when we're increasing cars, we're protecting health because we're less exposed to air pollution. So this in African cities, in some African cities, is very complicated, but the balance is always there. And that is why having policies focusing on one mode shift is not right. Having scenarios that do that is okay because we can always adapt for it or account for that. So the policies need to attack all modes at the same time for this reason. So yeah, great point.
They may even go in different directions. This is something that we can look at. And clearly, we have thousands upon thousands upon results. And you can multiply that with a kind of scenario space. But the results will not necessarily be linear. Once you take 1% of the car off the road, and the cycling might, maybe get more cycling deaths. If you take 30% of the cars off the road, you might get a very different situation.
Is that okay? Okay. So nice work. This is so incredible. I know bringing all the data together is such a lot of work, so, so one of my questions was, when I lived in Seattle, did the survey, and one of the survey, it said basically 46% of people that drove every day would never change their mode of transportation. They said even if gas was $10 a gallon, which is got close to, I guess, but they still wouldn't change driving every day because they liked it. They didn't like doing anything else. I mean, thinking about that challenge and like how you are modeling some of these things, like where can we bring in, I don't know, points on changing some of those perspectives or some of these really stubborn, ideas about changing modes to something else. A little bit more application beyond maybe what we're talking about, but I'd be bring that in here.
Yeah.
Okay, sorry.
I kind of because that's a kind of demand side. So
I'll ask a data question though.
Yeah.
Well, can you talk a little bit about how you dealt with where there's uncertainty in the mortality, injury mortality data, where there's a lot of, you don't know who hit whom all the time because there's a lot of benign codes or whatever. So yeah, we don't always know who hit who. You might know there was a pedestrian that died, but you don't know who hit the pedestrian. That's how you had some of that uncertainty.
Yeah, I mean, we are trying to represent some of this uncertainty as best we can, and you saw some representation of the uncertainty in the result there. In the integrated results, we also have uncertainty from many things coming together, and potentially we can analyze that. We are analyzing that with value of information analysis to see which of our input uncertainties is driving most our result uncertainties. You may have an input uncertainty is very great, but it's not making much difference for a given question. However, we have not run that yet. I feel I should also just Ali's here, give an extra big up for Ali and all the work he's done on this. But
redistributions type approach, or is it or what? Okay, so multi. Yeah. Okay. Okay, great. Thank you.
Yeah, great. I just had an input to your first question. I had a moment. I think one thing that we can add to the health impact modeling is that we're also modeling the economic value of this. And although it may seem a bit materialistic to think of it in that term, but being able to put financial value on mortality really helps to change perceptions already at policy level. So I don't think the impact of our work would be the same if we can't say, okay, we can save that amount of money if you're moving from cars to public transport. And unfortunately, that's a bit of an easy way out, but that's what we're so far. And we've been using VSL, the value of statistical life. Yeah.
And I actually always question the people will never, right? Until people do, right? So, it's the especially in cities like in the US, the sprawl's well, would you, if because the imagination think, well, if I gave my car, what would that? No, there's no way. Because some people would absorb a little bit of quite a lot of discomfort because they're convinced by the argument, but a lot of people won't. But the environment could also change, right? And sometimes these things don't factor it in. As Thiago is going up to set up his slide, one question actually I want to throw is just a very basic question. Are the assumptions around these behaviors standard across the year?
Yeah.
Okay, because the impact of different meteorological conditions, is there a way to kind of think about that?
I mean, we're trying to do something here at scale, and there's always trade-offs in the kind of complexity that you can deal with. At the moment, I feel that we've done quite a lot there to do this numbers of cities and to do it in this way. Doing more detailed work on a smaller number of places, you can start running more detailed models and analyzing. Of course, in some places there will be seasonal variations in behavior depending on the weather and so on and so forth.
So actually, one of the things I was thinking about is not necessarily places, or the types of places. So if you think about places that have the harmattan, right? I'm thinking from an air pollution perspective, right? Because not only is it drier and hotter, but there's huge spike in PM10, right, in terms of the dust air pollution. And so that kind of interacts with all of these things in terms of injury, in terms of air pollution, in terms of physical activity. So those those kind of typologies of spaces might be interesting. But yeah, I appreciate the amount of work. Okay, so I was kind of hoping the slide would be up so that we could segue into the final in countdown.
Well, I'm very conscious that I'm in between you and the gala dinner, so I'll try and be brief. Okay. Just before I go straight to the presentation, is this working? Yes, great. For full disclosure, now I have to say that I am a strong advocate of health impact assessment. I am a strong advocate of modeling tools to support health impact assessment. I used iTheme on my PhD under the co-supervision of James, and I have coordinated the global adaptation of the health and economic assessment tool for walking and cycling from WHO. Now, the tools are great, the results are great, but I would like to give a step back before I jump back into that, okay? And I have 4 points. So this is a picture that I took from Valencia a few days ago, and I loved it. I haven't seen how many interesting stuff this image provided, because here you have a very unusual sidewalk, innovative, great. You have somebody here with some sort of temporary or permanent disability. You have older people talking. You have a taxi. You have private vehicles. You have a bike share. You have a micromobility. You have people walking. So it's amazing. It's the type of reality we are not willing to produce. But when we go to a lot of the cities around the world, in fact, now if you have the right eyes, you will see a lot of similarities there. So my first point is, when we go to cities that are in principle less developed, or that have to improve their mobility, or that have to make their walking safe, we're all familiar with that. We all agree with that. But it's also important that we highlight what those places already have, and that oftentimes other places lost and had to invest a lot of money and energy to bring that back. So this is an example of a city in Morocco, Essaouira, one common street in that municipality. There we go. Now, back to the numbers. The second point I would like to make here is the importance for us to value local knowledge for action in transport. And many of you have heard already my WHO colleagues talking about the Urban Health Initiative in Accra. I would just like to highlight here that the beautiful numbers that you see on your left-hand side, and I won't go into detail there, they were produced together with the local people, not only for them to help developing the scenarios that would make sense for the policies that were being considered there or were in the pipeline, but also they were the ones fine-tuning the numbers. Like, they knew better the numbers, they knew better their reality. And I think that in that way, we not only managed to influence several key developments in the city, which are now resulting in interventions, but we also created this sense of ownership. So the numbers are important, the tools are important, but the process for developing a health impact assessment that is participatory, as you saw in Meelan's presentation and Haneen's as well, is equally important. Well, tools are very useful. I mentioned the WHO Health and Economic Assessment tool for walking and cycling. The online version that you see now is globally applicable. It's been originally developed for Europe, but thanks to the bright minds and energy of many people, it's now available to the globe. It's a very interesting way to facilitate this type of assessment in places where knowledge or capacity is not necessarily installed, but it's not perfect. And one of the aspects that I think we need to improve is on how we can best disaggregate the results. So if I were to invest my time and energy, I would invest less in over precision, trying to refine numbers that ultimately, depending on the value of that information, will not have any major impact on the results, and more on how can we make the results of these models and tools that we are producing more meaningful to move the agenda. Right? So if I don't have these results broken down by age, if I cannot make these statements for children or for older people or for women or for older women, then of course, we have a limit on what we can do with this type of application. And that's very much the case for heat, and we need to work on that as well. Oops, there we go. Now, my third point here is for us to try more and more now to connect the dots. So I am borrowing the inputs that you've just had seen from Meelan. Those are results from the health impact assessment done in Mauritius, the 14 deaths, the 20 million US dollars saved. But I put next to it the 8 domains of action to create age-friendly cities. And you will see that transportation and outdoor spaces and buildings are 2 of them. So we do not necessarily need to run of course, it's always better to have a more precise and tailored information to move the agenda on how cities can become more age-friendly. But we can already use the results that we have, because the scenarios that ultimately resulted in those gains will be beneficial for older people as well. So we don't need to wait until these tools are ready and adapted to use what they can produce to move the agenda. Well, also for getting together, I share here just one example. There are many others. No? Some of you may have heard already me saying this. We have a global network of age-friendly cities and communities doing outstanding work on all those 8 domains of action. Almost 1,500 cities in 47 countries, more than 300 million people covered, plus 18 affiliates, which are programs helping us support those cities and communities, which are highlighted here either in dark blue for national affiliates or in dashed blue for regional affiliates. Now, the map is not great, but even without the best resolution, you can see in some places of the globe, some big spots, right? Such as in Africa and Asia. So how can we also use these different entry points, transport, air pollution, climate change, on those areas to bring agendas together? And then conversely, how can we use the platform that we already have in high-income countries to make best use of health impact assessment for transport as well? Last but not least, and I think that this is my last slide. No, that's not my last slide, sorry. These people are doing great stuff, which we are compiling. And here, we are just sharing with you the WHO global database of age-friendly practices. You will have a lot of them there, and many of them are directly related to transport. And I can tell you, most of them didn't have their health impacts assessed, neither the economic ones. I will share very briefly 2 examples from that database, practices done from that large network that are related to what we are discussing here today. One of them is a little town in Ireland, Ennis age-friendly town, who through the age-friendly cities program that they have, organized walkability audits led by older people and people with disabilities, who will assess the terrain and decide what they want the municipality to change in their reality. And I can tell you, having more health impact assessments, both quantitative and qualitative, supporting their demand would certainly help. The second aspect that I would like to highlight here, and I've just mentioned the affiliate programs that we have, is that some of those affiliates are actually developing funding mechanisms to support cities and communities to take action. So they not only support with seed funds, just so that the communities can organize themselves, but also with the investments that are needed for changes to take place. And once again, this is just one example from the age-friendly space. I'm sure that the same would happen with the child-friendly space, with the climate change space. So my message here is really for us to try and get together with those groups that would certainly benefit from all the great work that you're doing, but are not necessarily aware or familiar or making best use of all this evidence and all these tools and methods that we have available. And with that, I end my short intervention. I hope I've managed to help connect some of the dots, and I thank you very much.
In the interest of time, I'll take 1.5 comments. Is that the 1.5?
Really cool how in your models you have city-specific information for the different things. So I was wondering if you could walk through how you would set up a simulation for a scenario where you wanted to increase mode share for a mode that doesn't yet exist in that city. Like, for example, putting in a new light rail line. Like, how would you do that if you wanted to?
Can I quickly comment on that? Because through the application of iTheme in Accra, that actually came out with electric vehicles. Now we have this as something that's commonly included in modeling scenarios. And the initial idea was that we would have a substantial share of that. But then thanks to the exchange we had with the locals, they said, look, in practice, we have this policy that didn't work, that policy, we have this gap, we have power shortage. So yes, let's make sure that we have that in a scenario, but let's adjust that to the reality that we face at the policy stage. For the technical part, I will leave it to the colleagues.
I mean, similarly in like kind of travel behavior models, you know, you just have to make assumptions and put it in something as close to, you know, if you're using rail, you might look at the bus values or something like that. You might say, well, in other places, rail is a bit safer. You put in some assumptions like we do about the walking to, you know, to access it. You know, those are the kind of, you're going to have to make it up, aren't you? But using the best assumptions.
Yeah, I don't even remember what exactly we used there, but we certainly had to use estimates, shares from somewhere else.
Yeah, great. Adding on to these two comments, there's not a lot left, but I think bringing in a bit of the work that we're doing as well in Cambridge with Tolu is that we are looking at transport infrastructure like rails, but considering walking to a transport infrastructure, but also creating these spaces for physical activity. What we're seeing now in the context of African cities is that a lot of this public space can be used for other reasons. So expanding the modeling out to mode shifts into physical activity spaces and other types of indicators. And here I know there's Evely's in the room. She's the star of Green Space, Health Impact Assessment. She's there, you can ask her as well. So trying to bring in all these different factors, right? You're putting in a trail line, but you're also putting in trees and places where we can actually start thinking about noise. And I know Haneen does a lot of noise as well. So if that helps, yeah.
That's a really good point to point out the opportunity of using that in terms of applying and pushing policy, using that what doesn't exist, an opportunity to say, yes, you could put that in, but if you put that in and put this other aspect in that either reduce injury or support physical activity, you know, think about it in a more comprehensive way, access to green space. Okay.
I mean, I think one of the things with models, we're trying to look at the relationship between assumptions, input data, and results. We're trying to use that to help people think through these problems. The models are not right, of course they're wrong, but you want to help you understand things better. That is what the models are trying to do. So you can put in different values. Look, what if you put in different values about safety? Well, if you put in different values about other sources of air pollution, they are a way to quantitatively look at problems and compare how your changes in your inputs would lead to changes in your results, which hopefully leads to improvements in how you can think about these things.
Any question on there? So I have one half question. I'll let you have the one and I'll take the half. To Thiago. We've talked a lot about the public sector and policy. And I wondered if you had inflection of the private sector. And I say this because in terms of the transport infrastructure, in a lot of cities being built, the financing is private. In terms of the investment money coming in is private. In what ways are we thinking about engaging in this HRA type work and looking at the rationale for doing this with the private sector?
Oh, we have to. And they're an important stakeholder that have to be on the table as well. It's the communities, the public sector, the funders, the private sector as well.
Do you have any examples, many cities that have successfully managed to engage the private sector in that way in transport infrastructure?
To engage with transport, let me think. Interestingly, not necessarily with transport, but with policy modeling. We have some colleagues working in Melbourne, for example, on pension policies, and they were using similar models to try and understand what would be the best policy environment for pensions. And most of that was driven or supported by the private sector. In transport, of course, I think that there's a big opportunity here, and I know that James has been working quite a lot on that as well, which has to do with how we plug in or combine or align, because most of the inputs of those models are actually outputs of transport models, many of which run by, developed, regularly used by transport companies. So I think that there's a lot there that we can do to bring them on board as well.
Yeah. And I think that argument of the cost is really strong. If we think about something like motorcycle logistics, right? It's huge and growing. So what is the argument for them to clean up their fleet and to, so kind of thinking about that opportunity, because they will need a kind of outlay upfront, and they'll be always looking at the bottom line there.
At the same time, acknowledging that some sectors will lose. If we want to change, then some of the sectors that are winning with the environment we live in today will probably lose. And we saw this happening in the past. And if we want to change the world in the direction we think is right for health and well-being, then some of those will lose, and we have to account for that in the political debate as well.
Okay. Final word.
No, that was just to add on to the example of private sector, because there's something going on in Uganda where the private sector wants to make an argument for introducing electric motorcycle. And they want to use this approach of health impact assessment to see what it would give to make a case for introducing that. So in that case, you see how the private sector even driving this kind of thing. So exactly. Yeah. Thanks.
Okay, great. I think with that, we're over. I think join me in thanking the speakers for a really engaging talk.